Hello, everyone. Thank you for joining us today. It's so nice to see you all. And
Hello.
today we are having a new session of our Boosting Leadership to Advanced Life Course Immunization course. I will be asking people to write down in a chat and introduce you with a simple question, which is, how do you want to be seen? And I will model this in my chat. So we start with see me as, and then for example, for me, for Sam, see me as a health activist and the proud uncle of two beautiful babies, my nephew and my niece. So I would love to see people, how do you see yourself? How can you write see me as, and then what else comes? See me as a strong advocate for immunization. Thank you. Thank you. Amazing. Let's see who else. See me as a health expert from India. Okay. Thank you very much. And let's see one more. See me as a health promoter and the father of three. This is amazing. Thank you. Thank you, everyone. And as we continue, please, in the next few minutes, feel free to continue writing in the chat. And I will be turning things over to Anu for our next slide, and welcome. Anu.
All right, thank you so much, Sam, and a big welcome to the Boosting Leadership to Advanced Life Course Immunization. My name is Anu Rotimi, a Boost champion and an immunization advocate. On behalf of the Boost, a program of Sabin Vaccine Institute, and along with our partners from Adaptive Change Advisors and People Power Health, we are delighted to welcome you to our fourth session together today. On the screen is our agenda for today, and today we shall be having a brief review of our last session and overview of the life course immunization technical module key takeaways. We shall also be having a presentation by researcher Camila Matos on vaccine hesitancy, social drivers in Brazil and South Africa, a case study presentation from our very own Boost champion facilitator in person of Tina Agboyima on building vaccine acceptance and demand. After that, we'll go into the public narration and we'll be using the type approach of storytelling. We're going to be doing our checkout and checking out about our own work. And today, something different is on board. Based on the feedback that we've gotten, we've considered having an optional discussion session where our facilitators and technical experts will be staying online after the close of the session for about 15 to 20 minutes or so to continue the conversation and answer questions that you might have. We welcome you to join us, but it's not required that you stay back. You are free to leave at the close of today's session if you do not wish to stay for the optional discussion session. I'm going to go through these slides very quickly as we did a full introduction during our course launch. By this time, I believe that you know our project team quite well, the Boost Court of Boost Champion Facilitator, the technical advisors who have been with us from the beginning and will be with us throughout the series. As a reminder, here is where we are in the Boosting Leadership to Advance LCI journey. In week 1, we introduced the course structure and provided an introduction to adaptive leadership and community activation. In week 2, our technical advisors provided an overview of life course immunization, and during which we articulated the gap between the aspiration of LCI and our current reality, as well as how to tell the difference between adaptive and technical challenges. Last week, being the 3rd week, we focused on identifying which population to target, as well as key consideration when introducing a new vaccine. Then we went through a stakeholder fraction mapping exercise, which is critical next step once you determine a new vaccine or target population. Now, today, we are on week 4, with a focus on building vaccine acceptance and demand, including building trust through storytelling. Next week builds on today's learning, and we will continue to build over the rest of the month. As I mentioned, last week we focused on identifying which population to target and why, the importance of tracking and surveillance data, key consideration when introducing a new vaccine, and how to map stakeholders fraction as a next step in new vaccine or target rollout. Before we turn things over to our guest presenters, I'd like to review some highlights from the vaccine acceptance and demand module you were asked to work on as the pre-work for today's engagement. As I'm sure all of you are aware, vaccine hesitancy is one of the greatest threats to global health, and it has been aggravated by the COVID-19 pandemic. In the module, a few strategies were shared, which you will be seeing several of those in the action in our guest presentation. 1, gathering inputs, really listening to understand vaccine hesitancy, perceptions, and motivations. Our first presenter, Camila Matos, will be speaking to this specifically, while our second presenter, Tina, will be speaking to several other strategies in our presentation, including how to address misinformation and rumors, build trust through community engagement, equip health workers to respond and be responsive, and planning communication in real time, as well as integrating vaccine delivery with other health services. A big thank you to Camila and Tina for being with us today. Our first presenter is Dr. Camila Matos. Camila is an assistant professor at the Federal University of Santa Catarina, Brazil. She is a qualitative researcher focusing on vaccine hesitancy and racial inequality in health. She has been studying this health phenomenon through social anthropological lenses, drawing parallels between Brazil and South Africa. Kindly join me in welcoming Camila. Camila, please, over to you.
Thank you. Good morning, everyone. Good afternoon for some of you. Well, it's a pleasure to be here. I want to thank you, the project team, for the invitation and for the opportunity to be here talking to you. So I'll be presenting a very, very tiny slice of my research on vaccine hesitancy. I am a medical doctor, but right now I'm in the social sciences field, studying how vaccine hesitancy drivers are somehow more complex than we are usually used to talk, right? So for us to start, we can, next please, slide. This what I'm presenting here is part of a big research that has been conducted in Brazil and South Africa in 2 different cities in Brazil, in northern Brazil and in southern Brazil, and in Cape Town, the Western Cape in South Africa. It's a qualitative research, so we conducted in-depth interviews with families and caregivers of young children. So our conversation here is all about storytelling today, and I think the qualitative research is an amazing way to approach storytelling, right? So the goal of this research was to better understand the social drivers, what we call the social processes behind the decision-making on vaccination. Next, please. And for us to start, I think it's important just to, we're talking about a great topic and a very highlighted topic right now in the world, that is vaccine hesitancy. So I think it's important to define, to explain better what definition we are using here, because the concept, the definition of vaccine hesitancy has been changing also, right? So we are using the definition of vaccine hesitancy as when someone is unsure or conflicted about or opposed to getting vaccinated. This is the more recent definition from the guide of the Measuring Behavioral and Social Drivers Working Group of the WHO. And they also define behavioral and social drivers as beliefs and experiences that influence the decision of getting vaccinated or not. Next, please. And this framework is also from the same guide I just mentioned. So in the middle, in the center of this picture, you can see the motivation domain. The acceptancy and the hesitancy are here in this part of this image. So the motivation includes acceptancy and hesitancy. And as you can see here, there are two domains that lead to motivation. They are the thinking and feeling about vaccines domain and the social processes domain. And here we are going to talk about the social processes domain. Next, please. And why do I like so much to talk about them? Because I think they are our greatest challenge regarding acceptance of vaccines. Why? Because the social processes domain includes things like beliefs, values, cultural background, lifestyle, gender, social class, race or ethnicity, worldview. So we're talking about things that are not that easy to access and to address. And that's why qualitative research in this regard is so insightful and useful and help us to understand all these drivers that are behind the decision to vaccinate or not. So now let's use some real quotes from real people's stories about vaccine and vaccination experiences on vaccination to talk about storytelling and vaccines, right? So next, please. Once again, this is a very tiny slice of this research. Let's use this example to talk about what is similar between Brazil and South Africa. So here we are discussing how social processes, how social positions influence the risk perception. So in Brazil, for example, we've got this mother saying that my son, who we take more care of feeding, who has a more suitable environment, he's obliged to take the same vaccine that that child who lives in the favela, who has poor sanitary conditions, who doesn't eat well, whose mother can't give him that support. And in South Africa, we've got this mother saying, if you talk maybe to white people around here, it's going to be different than if you go in the colored area. Maybe there in the colored area really is polio, or I don't know what other illnesses, or maybe they don't eat so well. We are very lucky that we can eat organic and we have time to meditate, and it's like they're trying to survive. So maybe if someone gives a free vaccine, it's better. And this shows us how the perception of one's position on the social net defines decision-making also, right? And in the next one, we have an example of what is different between both countries. So in Brazil, and this is very interesting because here we are talking about life course immunization. In Brazil, both Brazil and South Africa, this is important to point, both Brazil and South Africa have national immunization programs that are old and well established, and vaccines are free of charge. So both countries have this kind of established program, immunization program. But in Brazil, we do have a very strong life course immunization schedule. So we have our schedule is based on age range. So we do have vaccines for children, teenagers, adults, and elderly, and special groups. And this is a challenge we have here, even though it seems like we do have a very strong culture of immunization. It gave us a challenge also because people here perceive this very large schedule as an unnecessary thing to do, or as a way to make money, as a profit-making industry. So in Brazil, for example, we have this criticism of the vaccination schedule. So only in Brazil, we found things like when the doctor said there is this one, and this one vaccine, where I thought, oh, that's a lot of vaccines, I would say, which one is contagious? Okay, then let's take this one. And people select which vaccines they want to take. And another mother saying, if vaccines were given at an older age, I would certainly give them all without hesitating. So for me, this is the big problem, the age, that you have to get a lot of vaccines when you are a baby. And only in South Africa, we found the rejection of what they consider Western interventions. So in South Africa, we've heard speeches like, I am a traditional healer. I believe in my ancestors and traditions. So why should I go there while I could do it myself? I don't belong there. And this verb, belonging, is very interesting for us to think as social scientists and also health professionals. It's very interesting for us to think if someone believe they don't fit on that place, in that place, right? Why should they go and take something they believe they don't fit in, right? So this feeling of belonging is also part of the decision making to vaccinate or not. And another example of a father in South Africa saying, first of all, I've got a problem with these vaccines and all these Western things. I am an African, so I believe in African things. But now we are living in West while we are in the Southern Hemisphere. So as I said, these are examples of huge findings we had, just to point out how we do have similarities, but we also do have a lot of differences and specific reasons and drivers of vaccine hesitancy or acceptancy. Next, please. And for last, we do have what we learned, right? What are our lessons learned here? The first of them seems to be that one size does not fit all. And the second of them is that decision-making processes are influenced by people's beliefs and experiences. So vaccine hesitancy or acceptancy is not only about vaccines, it's sometimes about what people believe and how they feel. And how can those findings inform immunization policies? This is the greatest question mark here. It's important for us to think that as health professionals, we are used to find the problem and to look for a solution. And we are used to discuss defaulting issues and the solutions for them, and drivers like the distrust and the fear, and how to address misinformation. But how can we address social questions like those ones we just pointed, right? So it's important for us to think right now about these we're talking about, that we need immunization policies that are intersectorial policies, that are policies that dialogue with social sciences. We do need social sciences field to help us as health professionals, right? And we do have social change. Also, we have to address social inequalities, economic inequalities in regard of maintaining and achieving the vaccination uptakes we are looking for. Next one, and this is the last one. Thank you. I hope it was insightful. I'll be available. It's a short presentation, but please write me and let's discuss on the forums. I'll be available there too. And thank you once again.
Thank you so much, Camila, for that wonderful presentation. Now, I would like to introduce us to our next presenter, Tina Agboima. Tina Agboima is a boost champion and a health policy and programs implementation expert with more than 10 years experience working at the district and subnational level in Nigeria. And she also has 6 years of global immunization experience. She specializes in advocacy, communication, community activation, capacity building, adaptive leadership, research, and development. Please join me in welcoming Tina to take over the next presentation and technical session. Thank you, and over to you, Tina.
Thank you very much, Anu, for the introduction. Good afternoon, everyone. I'm happy to be here today. Camilla has linked me to the preamble, the introduction of what I'm going to give today. I'm presenting in Nigeria as my scope of presentation today is from Nigeria, Kano, and other southern part of Nigeria, if possible. Thank you. Next slide, please. So for me, I will be looking at the particular vaccine, which I believe is very close and very important for us for this topic as life course immunization program. I particularly feel that tetanus diphtheria for pregnant mothers and women of childbearing age is a good case study for this learning series. So today, the purpose of my case study is to see how we can eliminate tetanus diphtheria among pregnant mothers, women, and women of childbearing age, which we are targeting 15 to 49 years of age. So the learning experience at the end of these sections, we are expected to be able to apply technical and adaptive leadership skills to resolve immunization barriers leading to vaccine hesitancy and promote demand. 2, build trust and relationship among community members to fully accept vaccine with confidence. And thirdly, integrate other services to increase vaccine acceptance and advance the life course immunization program. These are the 3 strategic learning objectives for this section. Next slide. So as a communication person, I always go with pictorials when I'm doing communication. So all the series from the first and second series, I think most especially the 3rd series, we are looking at diphtheria. This is just a presentation, neonatal tetanus presentation. When you are communicating with people and they don't understand what actually is the vaccine all about, there's need to give a pictorial or a visual presentation explaining the causes, the root cause, the aftermath of the infection. This is what it results. This is why this vaccine should be accepted. And this is the essence of this pictorial here for communication purpose and for building trust. If people are to accept your vaccine, they need to see why they should take this vaccine. So we have here neonatal tetanus with a complete rigidity. It's a bit slight, where you have rigidity, and then there is also a case where you have a closed jaw. The child will not be able to suck after 2 days. After 2 days of birth till the age of 28 days, the child might develop strange physical look, and he might not be able to do the normal thing that the child is supposed to do. So this can be explained to the community and they can understand. If they have such cases, you start to see that they will report the cases to you. Next slide. So for us at the community level, at the implementation level, we have a lot of challenges. And these challenges can be adaptive, it can be technical. So I would like to just highlight some of the adaptive technical challenges, which when it occurs, you know immediately that you can fix this. And these are where we have issues like health workers' attitudes and commitment, low coverage, data quality issues and timeliness of reporting, gender-related barriers, lack of robust system for tracking pregnant mothers and referring pregnant mothers, no feedbacks to communities, and then no labor or delivery rooms in some health facilities. Then we also have these issues like shortage of antenatal care staffs. So these are technical challenges because you can, like in the area of the health workers' attitude, you can decide to organize an effective training on IPC skill, that is interpersonal communication skills, then monitoring and supervision to make sure they are committed in their duty, and that you can fix immediately. Low coverage, you can actually look at the areas where you have this low coverage, identify key areas where they are low coverage and what are the causes. Then data quality is also under training issues. You train and then make sure that monitor the timeliness of reporting. Gender-related issues are very much not, it's complex, but it can be reduced if you are in the system and you want to make sure that there's equity in distribution of immunization activities and positions to both the male and the female and vaccinating them. The lack of robust systems to track, yes, this is also a technical issue. We need to know how many human resources we have that can really map up the issues we have on ground. By the time you have insufficient community structures, for instance, to track pregnant mothers to health facilities or to identify cases, surveillance, and give reports, then it means that we are going to have a gap. So we need to quickly close that gap and make it work. Then feedback to communities. For the communities, they deserve to have a feedback of whatever activities that is going on, especially if we have issues of diphtheria cases, issues of women dying through labor and all that. The community need to be briefed how many, using data, facts, to buttress why these challenges should be addressed, the root cause, and then the community are also being carried along. These are technical gaps that needs to be closed, and it should be closed if it should be closed. Then, thank you. So, thank you. I think you can go back and check the others. Then for adaptive leaderships, challenges that we don't have immediate answers to. They are adaptive. You might have the answers, but you cannot just immediately give the answer because you might be hitting it wrongly. So like religion and cultural beliefs, rumor, misinformation. Then we have restricted access to services and supply. Then marginalized, disadvantaged communities, low education and financial constraints among women, conflicts, insecurity, and the migratory lifestyle of the community. These are very complex challenges that when you face them, you need to strategize properly to be able to give the answers to these challenges. Religion and cultural beliefs is a long-term challenge. It's something that has been within a system and requires gradual communication strategy to be able to address it. Rumor is also not good for vaccination because when you have a rumor, it distorts the whole plan, the whole efforts of the immunization programs. So rumor, they are some rumors are misinformation. Some rumors have some facts in it, but have not been verified. So for rumor, we need to actually see that we verify our rumors before we can take actions if they are true or not. So misinformation is something you just said, and there's no truth in it, and the people believe that, and they start spreading those information because they are ignorant about it, and so they use them to jeopardize the work of vaccinations. So I think financial restricted access. So a lot of communities, they are not as able to access some of these services because of their geographical barriers. They are not accessible. There is I would just say there is too many gaps that need to be covered there in those areas. So they need to really, really fix that up. It's not something that one can intervene immediately. Then low education and financial constraint among women. This is a long-term challenge, and it's also adaptive. Then all marginalized communities is a key area that we need to focus on, because a lot of settlements are marginalized, either because they are too far to reach, or they don't have people to really speak for them to get exactly what they want. So they use this marginalized community. They use the annoyance or the grievance they have to reject vaccine, not really because they wanted to reject the vaccines, but because they have been marginalized socially, politically, or otherwise, they become aggressive to introduction of vaccines. And so sometimes they tell you they are doing this because they know that if they reject your vaccine, they will draw attention to that place because they have been marginalized for a long time. So this has to be really addressed. And then there is conflict, insecurity, and migratory as lifestyles of the community. So this also is an issue, is an adaptive challenge. Conflicts of different types. It can be border conflicts, it can be tribal conflicts, it can be political conflicts. And so you need to, if you have such conflict areas, you need a serious team stakeholders to put together to be able to resolve such conflicts. Next slide. Yes, now this slide will just take us to all that I have just said, a story or an encounter with a household who has been very, is a non-compliance household, rejecting vaccine for so many years. And unfortunately, he became a casualty by losing the wife and twin babies that he was expecting. So I will just try to read it out. So we'll look at the case. What this case study is trying to bring out the different type of challenges that you can encounter in one non-compliance household. For instance, if you visit a household and he or she said, "I'm not receiving vaccine," there must be so many things surrounding his reasons for not resolving. You cannot solve one of these problems at once. So I just read, a household head lamented and said, "My wife and twin babies died during labor and delivery at home. I do not believe nor support institutional delivery and vaccination. My wife has never visited the health facility for any healthcare services. The 4 children she left behind were all delivered at home. She would have loved to patronize the health facility, but I did not give her my consent because of my belief and lack of trust in the safety of vaccine." This particular scenario, when I looked at it, I saw a lot of challenges here. Where do I start from? The man is a non-compliance household. He has not vaccinated any child. Even all the 4 children that were given at home were not vaccinated. They are all 0 dose children. He never believed in institutional deliveries. And there is also an issue of gender inequality or barrier here, where women stays at home and don't have the right to make decision. And then you see there is also religious or cultural belief. And then the lack of trust, which we are looking at, the lack of trust for the safety of the vaccine we are bringing. So if we are encountered with this kind of case study, we expect to treat all these issues so that by the time we are able to answer these questions one after the other, what are your beliefs? What do you believe in? What do you believe in? If you can get what the person believes in, you can be able to address his concern about what he believes in. Then why are your children not vaccinated? It comes also to that what he believes in. Then if you believe, do you believe that the vaccine is safe? And he said no or yes, but the religion or whatever he believes in has said no vaccination. So then why is your wife not allowed to go to health facility for other healthcare services, even if not for vaccination? And then also it's a negative answer. So in this case, it's a very critical case that we need to have this stakeholder or non-compliance, as we call them, to be able to understand the position of vaccine in protecting the life of women, children, and even himself. And that is where the life course immunization program will be very useful. Because in this case, he has lost the wife, he has lost the 2 children. So he's a casualty here. So I strongly believe that such cases are very many in the community. With the life course immunization, we had to look at the consent. The consent, no consent as a very big barrier that could hinder some of our programs in life course immunization, because if a man does not support the wife, he's the head of the house. If he does not support the wife for immunization, like TD vaccination that everybody knows, then if we introduce a new vaccine that is not very popular, there's going to be a stronger resistance. So we need to really look at these key stakeholders as the household heads, how we can bring them on board to understand that the life course immunization will really profit them. And that's that for that section. Then there's another section. I would just like the team. Okay. So what are the strategies that we are using in the field? What are the strategies we are using in the field to counter some of these issues that, like what we have observed in the case scenarios? We have some catch-up vaccination and opportunity for missed vaccination strategies. This catch-up vaccination is very, very helpful because it integrates other services like birth registrations, BP testing, vitamin A, and other counselings for women, opportunity to meet women and then counsel them. So it's very, very useful. Like here, we have a very strategized catch-up vaccination in a non-compliance, hard-to-reach settlements where the coverage was very low and it was very difficult to assess the communities. Based on the communication plan that was developed, the ACSM advocacy and communication plan, we were able to assess the community, and we had a very good coverage, vaccinating women for TB, children from BCG to measles, and distributing birth certificates for those that never had it. Yes, also, there's also the community engagement to activate and create ownership. People need to understand what vaccine is. A lot of people are not mobilized. They just come with the vaccine to the community, and that is why we have some resistance. So you need to mobilize and sensitize the community to understand what you are bringing, the implication. So we normally talk about the importance and safety of the vaccine. That is one of the things that brings rejection. So once they understand the importance of the vaccine, then they can ask questions. What are your fears about vaccines? Then if there are rumors about vaccines or whatever, you debunk it and make them to build the trust and confidence that whatever you come in with is going to be safe for them, for their children, and the entire community. So the essence of sensitization meeting with women, community influencers, and pregnant mothers was to give them the trust, build the trust, build the acceptance, make the acceptance, and increase demand for them. So now we have also another strategy which we use, and that is the town announcement to create awareness that a program is ongoing. And what was specific here and unique here was use of women as town announcers, which was not really common. So we selected very active and passionate women who were ready to debunk rumors and spread the information that vaccines like TT, tetanus, diphtheria are very safe, and it protects mothers and children from dying. So some of the messages that you need to know are there. So please, you can kindly read through them and digest them. So thank you. What are the results on the outcome? What did we find out? What did we get? We had increase in coverage of women that were vaccinated with tetanus diphtheria vaccine. We have a reduction in vaccine hesitancies. We have strengthened neonatal tetanus awareness and community surveillance. So these were some of the results after the implementation. What did we learn? We learned about how the high rate of neglected needs of women can be addressed through life course immunization, because most people we met were also asking for other services. So that inferred that if you have such services, it will help them and they will turn up. Then home delivery, as in an unclean environment, and the use of unskilled traditional birth attendants contributes to morbidity and mortality rate of pregnant mothers. So we saw that most of the cases we had, the places where they delivered and the person who was in charge of the delivery was not actually skilled in doing the work. Then household heads are willing to fully support immunization integrated with other prioritized services. So meeting with the men and during our community engagement, we found out that the men were also asking for other services, which means with the life course immunization, we'll be able to win the mind of the men to accept vaccine. Next. Thank you. I appreciate coming. I hope the presentation was okay, and I hope to see you in my next presentation so we can discuss and ask questions about vaccines and acceptance. Thank you.
Thank you, Tina, and big thanks to you and Camila. And I wanted to ask the group if just for a second you can show your faces and do a round of applause for both Tina and Camila for these wonderful presentations. Let's see some faces, especially because the second part will be more interactive, and we wanted to hear your thoughts. So Elizabeth, I'm happy to share to take over the slides if that's okay with you. Just for a second here. So both Camila and Tina talked about stories, and they talked about kind of like experiences in the field of people actually having their own stories about vaccination, why it matters, why it doesn't matter, and what are some of the problems with that. And that's why we thought that today we wanna connect their scientific research and experience from the field, implementation from the field, with a practice of adaptive leadership called public narrative or storytelling, if you wanna put it in a simple terms. And the idea of the stories and why that matter, they're in particular important because that's how you create informal power in the community. Like there are a couple of things that you want to do in order to create informal power in community. You want to start with the stories and narratives, then build the relationships, and then have some structure. And we're going to cover all three of them over the course of next 3 years. Three weeks. But today we are focusing on stories, and you will see in a second why that matters. So let me show you a video. It's a short video. It's a minute video, and I invite people to stay on their cameras, because we're going to have a little conversation here. There's no sound, so don't be surprised that there is no sound. That's normal. But I want you just to watch this video and tell us what has happened here. What do you think has happened? Okay, what do people think? What has happened here? Feel free to unmute. And I see Joseph here on the screen. Joseph, what has happened? Like, what do you think?
Thank you. I can see the circle being trapped, and the triangle is trying to remove the circle.
Okay.
And it's being targeted. Thank you.
Yeah. Friday, what do you think?
Thank you. I can see that the other triangle was not ready to share space with the other one, hence not fitting together in one space. Thank you.
Okay, so they're not fitting together in the one space. Ida, what do you think?
Me?
Yeah.
I'm not sure actually. I think it's kind of they are trying to attract each other. That's what I was thinking. And I don't know, yes, trying to attract each other and trying to influence each other. Sometimes they oppose too as well. that I was thinking over.
Yeah, thank you, Ida, and thank you, Friday. Yoro, go ahead. Like one last comment. I see your hand. Go ahead. Yoro, I don't know if you're muted, so you try to unmute. Probably that's a good idea. I don't know if it probably doesn't work, but there's a lot of stuff in the chat as well. So this is really interesting because what has happened is just a bunch of shapes and triangles moving around on a screen, and yet somehow we started developing stories. I don't know about you, but when I saw this video for the first time, I started developing a story in my head, like, oh, the big triangle wanted to get out, and then the small triangle. And that's what we do as human beings when we face new things. When something new comes to us, we're not going to the facts first, because the facts in this case are we have geometrical shapes moving in the random way. Those are the facts. But actually, our brain doesn't work that way. Our brain starts creating stories. And if you think about the exact same experience that communities and people have when you introduce a new vaccine to them or something that is novel that they haven't seen before, that's exactly where they go. They develop stories and narratives that can help them interpret what's going on, what has happened. And those stories are there for the purpose. Like as human beings, we have stories, as we say, like because the stories are the language of the heart. If you think about the facts being the language of the head, the way to give us the courage to understand what's going on, to understand the uncertainty, is to tell stories. And you need both of those things. Like, this slide is showing us that in order to take action, if you want people to take action and, let's say, vaccinate themselves, you cannot just provide them the facts. That's important. You have to do it. There's no doubt about it. But in addition to that, it's a good idea to also give them a story, a narrative that can help them take action. And that story has to be grounded in their own experience or your experience, as you will see in a second, and make a connection, make an emotional connection so people can relate to that. So the reason why that matters is that whenever we feel emotions, when people say like, oh, you should make a rational decision, there's no such a thing as rational decisions, because every decision activates certain emotions in us. And when it activates emotions, that means that we can then make a decision because we know what are the values, what do we care about, like what matters to us. So when a person that Tina shared in a community is not willing to maybe consider vaccination, you need to ask yourself a question: what is behind that? What type of values do they have? What do they believe in? What stories they're saying to themselves that is actually preventing them from making that decision and taking action? And trust me, in my experience working with communities across the world, there's no such thing as you just give facts and people will change their stories. If you want people to change their stories and change their hearts, you need to give them the story as well. And alongside with facts, not to ignore the facts. Facts are critical, and I'm a physician, and I do believe in evidence-based medicine, and we need to provide that. But in addition to that, I think we also need to provide the language of the heart. So how does that language work? Usually work in moments. Like, so stories, if you think about any moment, if I do this right now, clap, it created a moment for you, like something that you didn't know what to do. Is he gonna, stop the lecture, or what's he gonna do right now? And that moment creates an emotion, and that emotion then creates motivation because it activates our values. Like, oh, should I be scared of Peja? Should I jump off the call because, like, what's he gonna do next? But you see how it works. The emotion, like the moment that we created, creates an emotion. That creates motivation, and that creates movement, some kind of decision that you want to make. In the stories, when we share stories, this is exactly what we do. A good story has a moment that creates an emotion, and that emotion activates our values, what we believe in, and that moves us into action. When you think about good stories or good speeches, they always give us moments like, oh, I was there and this is what was happening, and whatnot. And in this particular way of practicing storytelling, which is useful for leadership, for adaptive leadership, there are three kind of stories that you can tell. You can tell a story about yourself, because that's important to build trust. If people don't know who you are, why would they trust you to take the vaccine? Think about it for yourself. If somebody asks you to do something and you don't know who they are, you have no idea where they're coming from, why they care about these things, would you do something with them? I don't think so. I think personally, I would say, like, who are you? Like, why should I trust you? And in many cases, we just believe that because we are health professionals, immunization professionals, that is enough for people to trust us. I don't think this group believes in that. I think there's, like, what I've heard and seen in the stories, there's a lot of kind of like, okay, we need to go deeper and tell some of the stories of self. So that's the first component. Sometimes it also needs a story of us, which is about how do we as a community deal with this stuff, and how do we in the past as a community dealt with this. And then the story of now, which is about why is it important right now? Why not waiting, like, as Tina was pointing out in her presentation, or I think Camila said, like, oh, I'm just gonna wait. Like, I don't know, I want to do it right now. I can wait because, like, there's something else going on. So if you think about motivating people, these three stories, the story of self, the story of us as a community, and the story of now, are critical to move people into action. So I don't want to talk too much because, we already heard a lot of kind of like, presentations and evidence and whatnot. I want to show you an example. And this example comes from this community by Marta Ngo. She's from Cameroon originally. She was a participant in actually this type of program, a different one, several years ago. And as you watch the example, think about, what did she tell us about herself? How did she create a sense of community? And what is the action that she's asking us to do right now? So if someone from the team can actually give me a thumbs up if the sound is good or you can hear it. But the name of the story is Left No One Behind, and here's Marta.
Let no one be left behind. Most often, we are faced with situations we didn't bargain for in this life. I have a cousin who at the age of 6 was doing so well in school back at the countryside because they could see cars on rare occasions due to the inaccessible nature of the roads. This cousin of mine at his tender age was so optimistic of becoming a civil engineer and to be the first person from his community that will construct good roads and buy a car that will ply these roads. Before my cousin could turn 7, he lost both parents. He was left all alone to fend from himself. That notwithstanding, my cousin remained optimistic, but before he could turn 8, he lost both limbs to the white polio virus. My cousin became an object of mockery to his community members and also to his peers who do not support his vision, as he has become physically disabled and lacks someone to sponsor him in that condition. I once visited him and asked him about his dream of becoming a civil engineer, but he burst into tears. He told me his dreams have all been shattered because he does not have anyone to sponsor him in that condition, and because the nearest school to his community was some 10 kilometers away, which was challenging for his situation. This reaction of his got me confused because I did not have the necessary finances to help him go through his education. All what I could do at that time was to give him some words of encouragement and promise him I will come back for him once I'm through with school and have secured a job for myself. As I moved on with my education, I came across a schoolmate who was quite intelligent, ranking among the first 3 in her class, but couldn't go through secondary school because she could not coordinate well due to bacterial meningitis that have affected her brain while she was still in junior secondary. This was also happening around me. Children from very poor families losing their destinies in the hands of vaccine-preventable diseases. I thought of fetching a menial job that could fetch some money to assist them financially. Then again, I had this classmate of mine that I was so fond of, but she couldn't go through her university education because she lost her mother through liver cancer that is caused by hepatitis B virus. I was so despaired. I couldn't believe that in trying to solve the existing problems I found, another will arise. Our dream of becoming the first female graduate from our community has been aborted because my friend had to drop out of school. I had to change my passion of becoming a pilot to that of a healthcare practitioner to first of all help sensitize my community on the importance of primary health care, especially immunization. Secondly, by working with humans who have stories of how desperate they have once been and how they receive help. And these are the people whom I know can easily give helping hands to others in need. We all come across some of these challenges in our daily lives. We just listened to Petra, who told us about the loss of her younger sister due to measles, and also to how Elvis lost a younger brother due to poliomyelitis. We can go on and on to mention the cases of lives that have been destroyed and destinies that have been thwarted because people weren't aware of diseases that could have been prevented through vaccination. What about those who are suffering but yet we don't know about their stories? And we want you to join me and become ambassadors for vaccines. Let our people know that vaccines save lives. That in this era of vaccines, no one should be left behind. Please join me tomorrow 10 a.m. at the community hall. Let's come together as a people. Let's seek for solutions to cut down deaths and disabilities due to vaccine preventable diseases and build a strong future for our children. Remember, let no one be left behind. Thank you. Let no one be.
Okay, let's give her a round of applause. So tell me just quickly in the few minutes that we have, and you can put it in a chat as well. What moments do you remember? Like what moments from Martha's story do you remember? Like if you can put it in a chat or share. Let's do some sharing here, and see some faces. If people can turn on the cameras, that would be nice as well. What moments did you hear? Soria, I see you. So you're the first one. So what do you remember from Martha's story?
Good morning.
Good morning.
The thing that stood out most to me is the devastation that was caused, I can't remember his name, losing his legs and his
Yeah.
dreams being shattered.
Yeah.
And it goes to think that if we have certain vaccines available, especially in the high risk and vulnerable community, that things like these will be prevented and persons will actually be able to meet their life goals, their dreams.
Yeah. It's so interesting. But she just didn't say like, oh, like in my community, our dreams are shattered, or like we don't. She gave us the specific people, the specific moments that she knows that help. It's really important to recognize that, because sometimes we think we are telling stories, but we are not. We're saying like, oh, our communities are suffering. That doesn't mean anything for people emotionally. It does mean like intellectually, but emotionally doesn't. And when she shared the details and the people who she met and worked with, and some of them are her cousins, we can feel it emotionally. And that's the difference. I think that it's worth paying attention. And I see a lot of people in the chat actually naming those moments, like specific people, specific stories that enable us to connect emotionally. In the storytelling work, everything is in the details. If you share the moments, if you share the details, people will be able to actually understand you and connect with you, because we share the human experience of what it means to lose a friend, or what it means to have a friend that is suffering because of something that could be preventable. But this was one example, and thanks everybody for amazing participation in the chat. but we also want to give you another real-time example. So Sam, I don't know if you want to quickly facilitate, or Adunola, if you want to jump in and share your story of self. Remember, we wanted to also model to you what you're going to do in the small groups, because we're going to ask you to share a little bit about yourself in this storytelling format in the small group, and wanted you to see how it could look like in just 2 or 3 minutes. So Sam, take it away.
Thank you, Peja. And thank you, everyone. So yes, Adunola is going to share her story of self with the group. So let's pay attention, and let's remember that the idea here is that she will be able to convey these story moments in under 2 minutes. Adunola, are you ready?
Yes, I'm ready.
Go
Yes.
ahead.
So I am the last child, and I come from a very large family. And of course, like I said, I'm the baby of the house. My dad was always healthy, and of course, he never got admitted in the hospital. He never fell sick until one day he was losing a lot of weight and going to the hospital to run a number of tests. I was quite young around that time. I was about 7 years old, and I didn't know what was going on, but I knew that he was going to the hospital and running tests. And I remembered hearing about fasting blood glucose and 2 hours postprandial for the first time around that period. I was scared and really sad to see my dad having to go through all that, because he had to be doing a lot of tests. They were taking blood from him. And eventually he was diagnosed to have diabetes. And he also now has to start using so many medications. As I got older, I found out that my grandparent had diabetes. And later on, my mom and an older sibling also developed diabetes too. And eventually my dad lost his sight due to a diabetic glaucoma. And of course, it was really a sad thing, because as a lawyer, you can imagine not having your sight. So recently, my nanny, a nice, hardworking young lady in her 20s, started losing weight and was always thirsty. So I advised she gets tested, and she was also diagnosed with having diabetes. I was shocked to see her test results, because my experience with diabetes in the past was of it affecting older people that were living sedentary lifestyles. And it made me realize that non-communicable diseases are not just diseases of aging. They can affect anyone at any age. So these personal experiences fueled my passion for raising awareness about non-communicable diseases. And I believe that everyone should be aware of the associated risk factors and the importance of choosing healthy lifestyle, making healthy lifestyle choices. I also believe that we need to break down the stigma that is associated with NCDs, so that people will feel comfortable talking about their health, and they will also be able to seek help. Because, for example, like my nanny, she told someone about having diabetes, and they told her, why were you eating too much sugar? She felt really bad, and it got her down. And I'm committed to using my platform to raise awareness about NCDs and to also empower others to take control of their health. And I believe that together we can make a difference in fighting against these devastating diseases. Thank you.
Amazing, amazing. Thank you, Adunola. I wanted to ask everybody a question here, and we intentionally didn't share a story about the immunization. It's about something else that Adunola is passionate about, and wanted to ask you, because there are immunization professionals here, you're all about the vaccines, but she brought us a different topic here, like non-communicable diseases. So would you join her? Would you trust to join her to actually work with her, even if that is not your topic based on this story? I'm curious, like if people, yeah, there's some yeses in the chat. Yes, okay. Let me ask Muhammad, because you're the first. Why? What gave you trust to join Adunola in this? You're working on something else, maybe that's not your topic, but why would you trust her? And actually anyone from the chat, because now there are a lot of yeses. Frida, I see you're talking, so maybe you can unmute and say, why would you just unmute yourself, Frida? Let me ask here, like, to see if we cannot hear you. Frida? Do you want to share again? We didn't hear you because you were muted.
Oh, yeah.
Yeah.
I'm saying yes, I would like to join her because my mother is diabetic and my elder sister is diabetic as well.
That's right.
So I'm ready to join her.
Yeah. So it's really interesting. That's what happens when we share personal stories. When we share personal stories, we open a space for people to see us in a different way, and therefore they can join us in the work that we do. And when you go into the immunization, next week we're going to talk about relationship building and how you build relationships. And that's going to be about changing whatever beliefs of people have and stories that they have about vaccination. But for today, we wanted you to practice the story of self. Because in order to get there, in order to even have a conversation about the vaccination, people who you're working with, they need to trust you. And trust is only built if you share a little bit about yourself, a little bit about your own heart, your own struggle, your own reasons why you became a health professional and why you became an immunization professional. And in my experience, we did like over several years, these courses, Storytelling for Change, and these courses. I've never met a single person in the Boost community that doesn't have a personal motivation to do this work, one way or another. Because interestingly enough, you don't choose this profession because you're going to make a lot of money or that's going to be, going to change your life. There's something else burning in you that is required to do this, despite all the difficulties that it brings. So it's really important to think about this in the context of inviting people to join you, especially when it comes to life course immunization and this work that is sometimes hard. Like how do we bring those stories of self into the mix? So in the next 15 minutes, what we're going to do, let me show you the slides here. What we're going to do, we're going to break into the small groups, and then in those small in those small groups, you will have a chance to share for 2 minutes, tell your story, like story of self, where you're coming from. Remember, 2 minutes is just for the purposes of allowing as many people to share, because we want as many people to share. So if you start talking too much, your facilitators will actually kind of ask you to wrap up and move to the next person, because we want to hear as many stories as possible. And then after the story, we don't just give it like that. We want to give each other a little bit of feedback. So how did the story make you feel? What moments do you remember? And maybe what were you curious about? What did you want to learn more? And then you can go to the next person. So we're going to do that for next 15 minutes. And then we're going to come back and have a little debrief of that experience. But remember, you will get as much as you give. So if you're willing to share your stories, that will give you more chance to receive from others and receive the gifts of their stories as well, and listen to each other. So Elizabeth, I don't know if you can put us in the small groups, but it's the time to do that. Yeah, I don't know about you, but in my group we just got started, so that is all good. Let's give a round of applause for all the stories that have been shared, I guess, in the small groups. I know they were at least from our group. We don't have a lot of time, but want to ask people in the chat, how did this feel? Like this first try, like what it would look like to share a story? How would that look like? What are you taking away from that? Like, from that experience, we often framework show you some models and then put you to practice. But what are you taking away? The time is too short. Aside from that, we know that, but like that's what life is as well. When you go into the community, you will not have a lot of time to share. They will give you some time. Because it's my own story, it's easy to share. Okay, it's connecting. That's great. What else are you taking away? Connecting and inspiring. Having a moment, yes. Not like a lot of, oh, I did this and this and this and that's just a moment. To be a changer, the ice breaking. Thank you for sharing, Asif. Yeah, okay, some thanks here. What else people are taking away? What are you taking away as well? This is just the beginning of this. We're going to continue next week in the relationship building. It's really inspiring. You feel relieved. Yes, that's so interesting. It's kind of like, you're sharing for others to connect with you, but you're also giving yourself a little bit of a break as well, and allowing to be fully yourself. Personalize the story. Exactly. Like it cannot be about someone else. You have to be in the story, as well. Drive to close the gap. I love that comment. I think this is where the connection between the work that you've been doing and these stories matter. Because when you have a gap, what Nicole was teaching us, when you have a gap and when you identify adaptive challenge, in order to mobilize those stakeholders that we discussed last time, you need to explain to them why they should trust you. What's in it for you, like why you're doing this work. And storytelling, especially the story of self, is something that can really, really help you build that bridge and start connecting with people that we're going to continue next week during our final session. So I wanted to just invite you as a homework, just to share this one last slide and talk a little bit about what's coming. Please do the post-session survey. That's all good. Next, we're going to talk about advocacy, financing, and policy-based evidence. But we're also going to talk about relationships, because advocacy, if you ask me, is all about relationships. Like, who do you talk to and how do you talk to them so you can move them into action? And in between, we want to invite you to share your story on a learning group. Share your story of self that you just started. Why do you care about life course immunization gap that you identify? So now we're going to focus on specifically the gap for this course, and the gap that is related to life course immunization that you are trying to do. What is your story behind that? Why do you care about that? And try to be as personal as possible, but also read other people's stories. Because last year when we did it, it was a beautiful, beautiful scene of stories that people shared in the learning group, but more importantly, how they comment on each other, how they read each other's stories and start seeing the connections and start building the relationships. So with that, once again, thank you, Tina, and thank you, Camila, for amazing presentations to talk about vaccine hesitancy here. And thanks everybody for trying this skill on today. We're going to stay for another 15 minutes. And I want to invite you, we have few options to do this work. We could continue being in a large group and sharing, discussing any questions that you might have about storytelling or about anything else that we discussed throughout these first 4 weeks. Or we could go into the breakout rooms and continue the storytelling work. So if you want to stay, put in a chat, what would you like us to do? We have those two options. Option number one, to stay in this large group and discuss and talk to each other, or to go into the small groups. So if people who are willing to stay for the next 15 minutes want to put, okay, there's a vote for one, staying in the main group, a couple of votes for that. Oh, there's now like a small group. So let's see. Oh, number one, okay. Yeah, we're not going to be able to do both, but we can promise you that we're going to do this again in the future. So there might be okay. It seems so far that most of the people want to stay in the main group. So for those who have to leave, thank you so much for participating, and for those who are staying, let's continue the conversation in the main group. I will stop sharing, and Elizabeth, turn back to you if you want to invite us into this.
Yes, thank you so much, everyone. So this is an opportunity. I saw in the chat that one person had a question, so we can perhaps start there. I also saw that Nook had invited someone to stay on to share, to continue sharing their stories. So perhaps we can move to that next. But I want to first open it up to that the person who it's now I've lost it. But if you do have a specific question, this is your opportunity to either ask it in the chat or to unmute and ask it for our presenters or facilitators or for the larger group. I found it. That was Serum.
And I think we have Adenike raise her.
Okay.
Yeah, Adenike, go
Sure.
ahead.
So my question, the story I shared in the small group was about my brother. And I want to ask, so what happened when a child is vaccinated and the child still come down with the vaccine preventable disease it was really, really bad. I mean, the child almost lost his life. So what would have gone wrong with the vaccine? Thank you.
Yeah, well, that's a great question. And Adenike, can I ask you a question about in what context are you asking that question? Are you asking like what to do as an immunization professional, or just in general, like how to address that question in a community if that comes up, if people kind of like share the stories like that?
What to do as a professional?
Yeah. Well, I will invite Camila and Tina and others to comment as well, but I have some thoughts, but I think they're bigger professionals than I am in this field.
Me just understand, I don't know what type of vaccine you are talking about. But first of all, if you have a case like this, you need to look at the vaccine itself. Then the health facility or hospital where the vaccine was taken, check the batch number, the expiration date of the vaccine that was given. Was it what stage of the vaccines? You know, we have stages. There are stages that you need to discard and not use. If the vaccine is no longer potent and you use it, definitely it's not going to work. So you have to look at that, the potency of the vaccine that was given, the expiration date, then the health worker itself who vaccinated the child. So those are some of the things you need to look at. And then how many people have this complaint? Is it a widespread case? Was it just the child alone? So that also you need to look at it. Then I think those are some of the things you first of all look at before you now finalize to say this is the reason why this is happening. Thank you.
Thank you, Tina.
Hello,
I think.
hello.
Yes, I think Marian had her hand up. Marian, did you have something to add? And then we can come back to you, Joseph.
Yeah, sure. So I just want to add that there's various reasons why vaccines don't work. And I put that in brackets because it's not that they don't work. We have to understand that each vaccine provides a level of protection, which is different depending on the vaccine that you select. But sometimes it's very difficult to explain that concept to the community. And we definitely saw that during COVID-19 when we moved from a strategy where we were going to prevent transmission, and then we moved to a strategy to say, well, now it's only protecting you against severe disease and death. And then people started thinking, well, is this vaccine working or is it not working? And I think there's a gap in what people understand on how vaccines work, but also healthcare workers, that the level of protection depends on various things. Firstly, was the primary series completed? Is this a booster dose? Which vaccine was administered, under which conditions? And then obviously the programmatic things that you have to consider. And then obviously the individual themselves. For instance, if this individual is HIV exposed, the immune response might be different. But when you engage with a family or a community, it's important to understand the entire context before you attempt to answer that question, because you can actually create more vaccine hesitancy if you are not clear as the correct cause of this problem. Thanks.
Thank you so much. Joseph, did you have a follow-up?
Oh, thank you. I think Marian had answered my question. Because vaccine is not 100% depending, so that is, as a health worker, that one somebody should put in mind, but should not give it to the community. Thank you.
I see a really great question in the chat. How do you tell a story to a community that may not relate to your story? Like with COVID-19, there are communities that have never seen an individual with an active infection. How does one go about that? Would any of our
I'm happy to answer that. And Bala, like I hope I'm pronouncing that right. This is really interesting. We encourage people not to, if they have immunization stories, they should share immunization stories. But the real question here is like, what do you care? Why do you care about other people? So your story doesn't have to be about immunization. It can be about examples. Where did you learn to care for other people? And believe it or not, like most of the immunization professionals do have those types of story, even if they don't have a particular immunization story. And that can allow you to build a bridge and connection, even with the communities that might not be experiencing that or haven't seen some of the stuff that they are facing right now. Because remember, what they are searching for is like, why should I trust this person? They're not searching for a particular example of immunization story. They're in search of like, who is this person in front of me? Why do they care? Where are they coming from? And you have plenty of other stories in your life, and as everybody do, that you can share in that context. It doesn't have to be the story about immunization at all. So I see Nahad, your hands raised as well.
Hedja, I like the way you described it as an example, because when we think of stories, it doesn't have to be like a 10-minute sort of storytelling. Also, it could be analogies, right? It could be examples or similes. And the reason I mentioned that is that when I was the director of a local public health agency during COVID, what I realized is in order to make COVID situation tangible and digestible, I could try to use some football-related analogies, which I would employ in my public hearings and public forum in order to make a very abstract concept kind of resonate in a tangible way with our community members. So I just wanted to again highlight your point around examples, because we kind of mix that up sometimes with long-winded stories as well. Over to you.
Yeah. No, that's great. That's exactly right.
I see a question in the chat about asking for a little bit more explanation about values, loyalties, and losses. And this is, I think, very relevant for today's session, and we see how these sessions build on one another, because in some of the cases where you are hearing different people's rationale or reasons for vaccine hesitancy, an important way of creating that connection is to really understand the value that is underneath it. So if someone is saying, I'm worried about the safety of the vaccine, I'm worried that this might cause harm or hurt, what you can hear in that, instead of hearing they don't want this, is you can hear, what I'm hearing is that you value health and wellness, and you want to make sure that your family is safe. And that creates a point of connection where you can tell a story that really reaches people, but really understanding their values and what they care about then helps you to create those points of connection. Milk, I don't know if you want to also share a little bit more about values, loyalties, and losses as well. That was just an example that I heard from today's session.
No, that's perfect, Elizabeth. It's a perfect example. I'm curious about those of you that were present last week. What do you remember about that conversation about values, loyalties, and losses? And let's connect it to story and what we're talking about today. So part of this, learning experiences to learn from each other. Remember, we don't have experts here, so I'm not an expert, and I'm disappointing you right now with no answer. So those who someone might have an answer for us in the group. Values, loyalties, and losses. What do you remember, and how does that connect to story? Can I pick on Peter? Peter Boniface. You're in front of me, so I'm picking you.
Oh, hi everyone. I think when you talk about values, more about not what you are bringing to the community, but more about what you can achieve together when you work together with the communities. When you are addressing the communities and hearing their stories and their challenges and their struggles, try to find a way where you can link with them and provide solutions which are not entirely yours, but more about them arriving to that conclusion that together we can achieve 1, 2, and 3. And when you talk about loyalties, it's more about you becoming an ally, becoming a partner, becoming someone who is supportive to the communities, regardless of their stance, their concerns, how their approach to solving their struggles, but become an ally where you take the opportunity to understand where they are and also take them through the journey where you can say, if we are together, I'm your partner, I'm here to support you, I'm here to educate you, I'm here to train you, but together when we come together and join forces, we can achieve this. Losses is more, even though there are always financial losses, there are always time wasted, there are always infrastructures and all, but the big loss will be when you fail to reach the community, when you fail to motivate them, when you fail to inspire them to take the action to make the changes. That is the big loss that I can see from here. Resources, you can always get more. Infrastructure, we can always rebuild, but it's the trust of the community that once it's gone, it's very hard to gain. I think that's my perspective on those 3 issues.
Perfect. Thank you, Peter. Next week, you are going to be one of our co-facilitators. Wonderful. Back to you, Elizabeth. Thank you, Peter.
Thank you.
Yeah, Peter did a great job of really sharing what we talked last week about the different stakeholder factions and understanding the values, loyalties, and losses of those different stakeholder factions. And Peter did a fantastic job of talking about the immunization professional, or you doing that work, those values, loyalties, and losses. So that connection to your story about the value of making sure that you're connecting with community and really making sure that you're being a partner with them, making sure that you're understanding the losses and the loss to you and to your work if you're not able to build that trust and create those relationships. And so this storytelling strategy as one of the ways to build trust and continue your work. We are at about 15 minutes or a little bit over 15 minutes now. So I think we can close out for now, but we appreciate so much you staying on to continue the conversation. I heard something that somebody—
Sorry, just one more question. There's a question by Khadiza, which is really interesting one. Khadiza, do you want to voice it out? Well, I think I can answer it in a minute or two.
Okay, hi. I recently met a lady that was battling cancer, and she was struggling to kind of tell her own story, but she noticed her community or where she participate in, she's not fitting in well because people are now discriminating her as a cancer patient. So I'm looking at why will someone be kind of discriminating a cancer patients, not just cancer patients. I noticed that disabled persons also face some kind of challenges too around my community sometimes, and I am looking at what can we do better, like to encourage those people to still voice it out while we advocate for those to stop the stigmatization. Thank you.
Yeah, I love that question. I think I can answer it relatively briefly. There are two components to that. One is that not everybody is ready to share their story. If she's going through through that experience, it's a hard experience, and we have to respect that, and honestly, not sometimes even ask for the people who are going through that experience to share those stories. But to your other point, Hadiza, is like, what can we do about facing and challenging discrimination? I think it's really interesting because that's where even your story that might not be, for example, you might not be facing discrimination, but you, almost every human being, has an experience of being excluded sometimes. Maybe you were a tall kid in your class and everybody looked at you and said, like, you're so tall, or you were a short kid and then everybody said you're short. Like, so this idea of being excluded is a common human experience. And sometimes I find it to be useful to actually speak about your own experience that is not of that patient or a person that is struggling with some other things, but your own experience of exclusion, so people can remember that and say, like, oh, I was excluded as well. I should not do this to other people. So that's the way to actually in these moments maybe encourage or help people see that the discrimination is something that is bad. The other thing that we're going to cover next week when we do the relationship building is to ask for their stories. When you do a relationship building, you will ask them to their stories. And sometimes you can ask, like, have you ever been excluded in your life? And guess what? It's hard to find someone who hasn't been, on one way or another. And once you evoke that experience, then asking them to stop discriminating is not coming from you, it's coming from them because they know what it means to be excluded. But we're going to cover that next week, and I think you will enjoy it as well.
Thank you very much. Thank you so much.
Fantastic segue, Pedja, and getting us ready for next week. So stay tuned for follow-up, where we'll share the recording, the slide deck. There's already a forum post where you can share your stories and your ideas. We'll send out those follow-up materials and look forward to seeing you next week. So thank you, everyone, and we will see you then. Goodbye.
Bye.
Thank you. Goodbye.
Bye, everyone. Bye.
Bye.
Thank
you. Bye,
everyone. Thank you. Bye bye.
Bye. Thank you.
Bye, everyone.
Bye bye. Thank you.
Bye.
Bye. That was good.
Bye, everyone. It was really an interactive session. Thank you.
Bye, everyone.